Take 5 seconds to pause the video, read the question, and then we'll go through the answer. Okay, so we've got a 28-year-old female past medical history of alcohol use, presenting to the emergency department with palpitations and tremors. She denies any chest pain or nausea. Patient states that she recently started using cocaine, approximately 2 months prior. EKG reveals an irregular rhythm with an erratic baseline and absent P waves. And she has an approximate heart rate of 140, okay? So an irregular rhythm, the big thing is atrial fibrillation. Whenever you see that, you think of AFib. And you might be saying, okay, well, what about torsades? It's true, right? It's potentially, she could potentially also have torsades here. However, for her to come to the emergency room with this rhythm and be conversational, right, it's much more likely in general. If you're going to play odds in these situations with erratic baselines, absent P waves, there's no mention of twisting of the points or anything like that, then they're talking about AFib. So these are the things to just be familiar with, right? Even though torsades is irregular, they're usually going to give you more information. These are all very classic descriptors of AFib, erratic baseline, absent P waves. Okay, so she has an approximate heart rate of 140, intravenous and IV drug is administered. The patient reports becoming very anxious after the drug is given. A cardiac monitoring rhythm strip taken after the patient receives the IV drug is also shown. So really so first of all, this is a wide complex, okay? It's very random, right? Completely random, completely irregular. This is going to be ventricular fibrillation. There's no organization to this whatsoever. As this happens, looks like the patient loses consciousness. Acute resuscitative measures are initiated. Okay, which of the following IV medications were most likely given to this patient? And once again, I'm sorry for leaving you in suspense. I forgot to click the next slide. So the answer here is diltiazem. So let's just go through this really quickly. So again, this patient has AFib, and we've already kind of talked about this a couple times. But again, if you have AFib, right, so my left atrium, my right atrium, my SA node's over here, here's my AV node, right, and then my left atrium is firing all of these signals because I have AFib, right? It's firing from the pulmonary ostia. We already said this patient had an irregular rhythm, right? Consistent. These findings are pretty consistent with AFib, and we got about 140 beats per minute heart rate. Now, if the doctor said, hey, this patient has AFib, let's get the rate under control, but this patient actually had an underlying accessory pathway that we weren't aware of, right? So all of these signals are bombarding the AV node. Now I take diltiazem. What does this do? This is a calcium channel blocker, right? Class 4 antiarrhythmic, right? So what is that going to do? So remember, this is going to block L-type calcium channels, right? So it's blocking the L-type calcium channels, works really well at the AV node to help slow the heart rate down. It's great for rhythm control in AFib, except if the patient has an accessory pathway. If the patient has an accessory pathway, now these signals, instead of all going to the AV node, they're going to bombard this accessory pathway, right? And I'm not going to get any refractory period from some of these signals. So this firing at 4 to 500, it's going to hit the ventricles, and the ventricles might go up to 250, 300 from what was 140. Okay, so essentially my AV node was doing a good job at having a refractory period and absorbing some of these signals from the AFib, but now I have this accessory pathway and I blocked my AV node completely, so everything is bypassing it. So in this situation, we can see that this patient probably went into VFib because we shut down the AV node, and now everything is going straight to the ventricles, okay, and now they're in ventricular fibrillation. In these situations, normally what you would do if you know the patient has WPW and they have AFib, you would want to think about something like a class 1A. Procainamide is really good at this. Quinidine also is a good option. Now, remember, if the patient actually had torsades, right? If the patient had torsades, we definitely would not want to be giving procainamide, right? Because again, procainamide the downside to it is that it can delay the QT interval. Okay, so it can delay the QT interval, but it's not an AV nodal blocking agent. AV nodal blocking agents we want to avoid in WPW. Things that prolong the QT we want to avoid in torsades. Okay, so you kind of see how this is all coming full picture here. Amiodarone is usually a safe play because it's kind of like a little bit of everything. Again, it doesn't classically delay the QT. It does have some effects at the AV node, so it would definitely probably be a second choice to procainamide in this patient. And then ibutylide, you can also make a case where it probably wouldn't be in the top here. But in general, in this patient that we're talking about in this question, the number one thing you want to avoid, the number one thing you want to avoid is going to be AV nodal blocking agents. Okay, specifically, we're talking about calcium channel blockers. We're talking about beta blockers because they act, very specific. They act very strongly at the AV node. We want to avoid digoxin, right? Because digoxin will increase our vagal tone. We would definitely want to consider avoiding adenosine in this patient, and we would also want to avoid vagal maneuvers, right? Anything that's going to block my AV node in this patient is going to make this AFib a lot worse, right? We're going to get the ventricles bombarded with signals. So in general, the safer play in this patient specifically would be a class 1A or class 3 antiarrhythmic, or even you can say a class 1C would actually work as well. But the 1As and the 3s, these are the ones that you would avoid in torsades or QT prolongation, where you would avoid the AV nodal blocking agents, again, in this patient with an accessory pathway in AFib.